Hello everyone. So we continue our discussion about reproductive endocrinology and now I'll be doing part 5. A 25-year-old man, problem of erectile dysfunction and low sexual drive, height 187 centimeter, fairly tall, BMI 21, spare facial and body hair with gynecomastia. Testes are small in volume and firm in consistency on palpation. FSH very high, LH high. This is normal and testosterone level is reduced. So we are getting high LH, high FSH and low testosterone. Most appropriate management of this course is testosterone replacement therapy. Why this answer? Why not others? So this is a classically case of Klinefelter syndrome. The reason being tall person with low testosterone and high LH and FSH. So in Klinefelter syndrome, the cornerstone of therapy is by testosterone. It should be started during puberty at the age of 13-14 years and dose increase gradually to maintain age-specific testosterone and LH level, and we keep on monitoring. The mainstay of treatment is testosterone. A 25-year-old man referred to endocrine clinic for again erectile dysfunction, tall man, BMI normal, same old previous question. But now the question is something different. All the following may be there except, that means the option given, now he's talking about the clinical features. What can be there? How we treat a case of Klinefelter syndrome that he told in the previous question is testosterone. But what are the clinical findings we'll be getting in this patient except kyphoscoliosis? So, tall stature, number 1. Gynecomastia, number 2. Small firm testes. And with the primary suggestion of high LH, FSH and low testosterone, they suggest Klinefelter syndrome. So we are got it. It's a 1 in 1000 males. There is an extra X chromosome. Okay, it is XXY is there. There can be even XXXY can be there. This is 47 or 48 chromosome. So these are the classical findings that we see in any case of Klinefelter syndrome. Now, one more thing, more the X number of X chromosome, more are the somatic and psychological problems. Now, in these cases, Klinefelter syndrome, 71st debut, they undergoes extensive fibrosis and hyalinization occurs in the accelerated phase in puberty, leading to low testosterone and androgen. That's why, since the problem of testes getting fibrosed start at puberty, so better to start androgen therapy before this problem starts. But once the problem is over, then it becomes difficult to take care of this thing. So that's why we start with testosterone in early stage. So in the absence of feedback of gonadotropin, FSH and LH are significantly elevated. Now in these patients, there are increased risk of breast carcinoma. But these patients already have gynecomastia. That's why in these patients, it's mandatory to do the mammography on periodical basis. Aortic valvular lead disease, echocardiography should be done. Mitral valve prolapse, in 50% cases this can be there. Bronchitis emphysema, that means COPD. Osteoporosis, pulmonary embolism, Berry aneurysm, they're all associated finding in these patients. Now, if you look into the option choices, yes, can be occur, pulmonary, yes, this all can be. Kyphoscoliosis is usually not a feature. It is often seen in Marfan syndrome, not in Klinefelter syndrome. Question 3, we are getting a 52-year-old man, Klinefelter syndrome, and now unwell, backache, weight loss is there. Testosterone replacement therapy was given with the early teenage group age. FSH is still on the higher side, LH is still high, and testosterone is still low. Now, most appropriate next step, what to do? In this patient, best examination, very simple. Klinefelter syndrome, 99% when they will ask a question on Klinefelter syndrome, they will always talk about breast, maybe carcinoma, breast examination. So we have seen that the investigation we are getting, and we have given testosterone therapy, okay, and fairly we are able to control the finding, although not fully controlled, but near control, because these figures are usually very high, and this is usually very low, but now slightly on the border zone. So if you are sure about Klinefelter syndrome, before you do any other investigation, go for breast examination, simple. Otherwise also, it's a physical examination, which we do as a clinician, as a physician, we always do. First thing is examination, testing, investigation, imaging, all come later on. The bone scan later on, CT abdomen, no way, digital prostate, no way, myeloma screening, nothing. First, and we have a relevance of knowing that Klinefelter syndrome may develop breast cancer. Okay, so Klinefelter is increased incidence of breast cancer. Other cancer that are common in these patients are non-Hodgkin lymphoma and lung cancer also. But since this is one thing which we can very well know by simple examination, of course, non-Hodgkin lymphoma we can see for lymph nodes. Okay, this will have some history of cough. Periodic breast examination and mammography for breast cancer is recommended for men with Klinefelter syndrome. Question 4. We are getting a 17-year-old girl, menstrual irregularities, increased facial and body hair, attained menarche at the age of 13 years, normal secondary sexual development, and she has a stable relationship using a barrier method of contraception, and BMI 32 on the higher side, increased facial and body hair, there is no proximal myopathy or no bruisability, nothing is there. Estriol level are in the normal range, FSH normal range, LH on the higher side, testosterone is on the higher side. Most appropriate management of her menstrual irregularity, the answer is oral contraceptive pills. Why this answer? Why not others? Let's look into the case. So we are getting a irregular menstruation, and there is hyperandrogenism. Why? The testosterone level is increased. So this is a classical, this is how we are thinking that we are getting in case of, we are getting PCOS is the likely diagnosis in this case. Oral contraceptive pills with ethinyl estradiol and low progesterone level is the first line treatment of menstrual irregularity in a case of PCOS. And remember, there is a hirsutism is there due to increased androgen. Aim is to regularize her period and reduce androgen excess. This is the aim. So once we are giving estrogen, that also increases the sex hormone binding globulin. So definitely the testosterone will go and bind to this, and that will lead to reduction of the free testosterone level will be reduced. And the free testosterone level will reduce the androgenic effect. Androgenic effect will be reduced. So reduction in the androgen level will result in reduction in the thickness of the facial and the body hair. In fact, all androgenic factor will be reduced by giving estrogen. Now, female who fail to respond to OCPs and they have hirsutism, then we give anti-androgen therapy. Anti-androgen therapy is a second line treatment after giving estrogen. We can give cyproterone or we can give spironolactone can be given. These are anti-androgenic molecules. Then for hirsutism in the facial hair, we can use eflornithine. This is for mild hirsutism. But advantage is it's a local application, so it has no effect on the menstruation. Okay. And one more thing regarding when we are giving spironolactone and cyproterone, they have a teratogenic effect. So that's why they should never be given in pregnancy. Question 25, 25-year-old woman, menstrual irregularity, and the hair on the face, BMI raise, and there's no history of myopathy and easy bruisability. Polycystic, we make a diagnosis of polycystic ovarian disease, which is the result consistent increased testosterone level. This we discussed in the previous question. Testosterone level was high, and that was the main treatment. Main problem is increased androgen. For that, we give estrogen therapy. We want to give estrogen so that sex hormone binding globulin should be raised, and that is going to bind androgen. Well, the raised testosterone level is the finding. Biochemical changes that may be seen in patients with polycystic ovarian syndrome include reversal of FSH and LH ratio. Classical finding is this. Low level of sex hormone binding globulin, and that we want to raise by giving estrogen. And once this level gets raised, that is going to bind to testosterone, which is high. This level high, and androstenedione is raised, so androgen are raised. So when we give estrogen, that is going to cause the level of this will increase. When the sex hormone binding globulin level will increase, it will bound to more and more testosterone and DHEA. In that way, the androgen level will go down. Question 6, 35-year-old lady, and she has excess facial and body hair, menarche at the age of 13 years, dysmenorrhea, that is painful menstruation is dysmenorrhea for the last 2 years, and for the last 2 decades for which she had been on oral contraceptive pills. Okay, she has no family yet to start, although she is in steady relationship. BMI is raised, excess hair, and there is no feature of proximal myopathy and bruisability. On investigation, what we find, FSH, LH, and estradiol, they are fairly in the normal range. But testosterone is definitely raised. So what we find, something very interesting to talk about, we are getting increased testosterone, LH, FSH, and estradiol are fairly in the normal range. Now we are getting multiple cysts in the ovary on ultrasonography. That means that goes in favor of polycystic ovarian disease, and hirsutism is there. What to do? Well, the best answer, this could have been the answer, but here the answer is spironolactone. Well, this is always the first line treatment in a case of PCOS, as we discussed in the previous question. But here the estrogen level are in the normal range. So we like to go for additional drug that will going to help to take care of the hirsutism. And spironolactone, it is an anti-androgenic drug. Even this is also, this is there to induce ovulation. But here the problem is of hirsutism. So now we like to add something, a drug which is classically or specifically, which is an anti-androgenic drug. Of course, we know this is a potassium sparing diuretic also. Okay. So we can try for anti-androgenic drugs like spironolactone or flutamide. Look for hirsutism, which are not responding to mechanical method like waxing or shaving. Okay, so they are generally avoided in patients who have fertility because they have a teratogenic effect. So definitely in the patient who first want to reduce the androgenic effect, you try this drug, but when they want to conceive, stop them. 24-year-old woman, menstrual irregularity, hirsutism, and without any cushingoid features, FSH, LH, estradiol, testosterone. Okay. Well, we are getting high amount of testosterone. So when you do ultrasonography, what type of picture you get? Now something, it's the other way around. Lab finding are there. Now he's asking what finding you will get in ultrasonography. We get follicular string of pearl appearance. Okay, what is this? So let's talk more detail about this thing. According to Rotterdam criteria, diagnosis of PCOS is based on presence of 2 out of 3. 2 out of 3. Menstrual irregularities, that is will always almost there. Hyperandrogenism, increased androgen level. A third is you are getting polycyst in the ultrasound. These are the 3 criterias. Okay, 3 criterias. Now when we do ultrasonography, you may get bilateral enlarged ovaries with multiple small follicles, or you can get increased ovarian size of more than 10 cc, or you can get 12 or more follicle more than 2:9 millimeter, or we can get D, peripheral follicles make string of pearl appearance. So different findings can be there on ultrasonography. Okay, still not clear. Hypoechogenic ovary without individual cysts. That means cyst may not be there. Although we call it to be polycystic ovarian disease, but it's not necessary it will be there. So there's something. So presence of ovarian cyst on ultrasound is not a prerequisite for diagnosis. So that's why any 2 out of 3, menstrual irregularity, increased testosterone level, and polycyst, any form, any 2 out of 3 should be there. Well, pathogenesis of PCOS, exact pathogenesis is not known. Although ovarian steroidogenesis dysfunction is a contributing, imbalance in pituitary or hypothalamic hormone secretion LH, FSH imbalance is a strong predictor for this. Insulin resistance, that is a part of metabolic syndrome, they play a role in this pathogenesis of PCOS. So I hope you are clear about it, that even in the case of PCOS, the cyst may or may not be there. Thank you very much. God bless all of you.